Hello, Prof. Good evening and welcome.
Good evening. Yeah.
Yeah. Prof, I think we can start whilst the others join later.
I wanted to find out with the group if we have done hematological malignancies. Does anybody remember if you've done that? All right. So I don't suppose we have done hematological malignancies yet. Can anyone confirm? Have we?
No, please.
Okay.
No, sir.
All right. Then we will look at it today. And see. All right. So we will have a brief overview of the hematological system, and then the malignancies include leukemias, lymphomas, and then myeloproliferative neoplasms, such as the increment in red blood cells and platelets. So the leukemias are placed into two categories: acute leukemias and chronic leukemias. You start looking at the acute, which is sudden occurrence. Okay. All right, a moment. Okay, so for the acute, the patient present with pancytopenia. That is all the cell lines are usually diminished in number. In that case, you have symptoms of anemia. That is red cell deficiency. You have signs of infection. That is white cell deficiency because there is no immunity. And you have signs of bleeding, which is platelet deficiency. So signs pointing to pancytopenia will be showing in acute leukemia. Diagnosis to death is 6 to 12 weeks if untreated. If it's treated, it prolongs. And then is sensitive to chemotherapy. And the best initial test is blood smear. Sometimes you see it inadvertently or by accident when you just doing blood film and you end up seeing a lot of blood cells present. And the white cell count can be low, normal, or high, depending on which stage. Yes, but as we have mentioned that there is pancytopenia, then ideally you expect a low white cell count. This is what you see in the blood smear, a lot of blood cells, young white cells filling almost everywhere, similar to the one here as well. And then the chronic, the patient presents more slowly or insidiously, so it doesn't happen all of a sudden. And it is believed that if it is present at a routine checkup, that is when the person is not sick and you pick up this type of leukemia, then it's more likely to be chronic. Less likely to present with pancytopenia. Okay, so diagnosis to death is up to 12 years, even if untreated, and is less chemosensitive. Best initial test is full blood count, and the BBC count is always high. You look at white cell differential, and you can find smudge cells if it is chronic lymphocytic leukemia, because the lymphocytes become smudged when we make a blood film. So if somebody isn't really sick and they show up for test and you find a leukemia, then you are likely looking at chronic leukemia. That is smudged lymphocytes that we see. Okay, right here, smudged cells. They are made from lymphocytes that have become malleable or soft in the way so that when you make the blood film, they sort of become mated. Now, to classify the leukemias, we've already mentioned chronic and acute. So if we have lymphocytic or myelocytic, then both of them are going to have the acute and chronic type. So we have acute lymphoblastic leukemia, ALL, chronic lymphoblastic leukemia, CLL, acute myeloid leukemia, AML, and chronic myeloid leukemia, CML. And the acute chronic is as a result of onset and progression. And then the lymphoblastic and myeloid is by the cell type. And of course, leukemia is the main deal. Okay, so with the acute and chronic myeloid, they affect the common myeloid progenitor cells. So cells that produce the basophil, neutrophil, eosinophil, monocyte, thrombocytes, and even to some extent erythrocyte are the ones affected, but usually will affect the myeloblastic stage. Then ALL, CLL affect the myeloid lymphoprogenitors, And these progenitor cells give rise to B and T lymphocytes and natural killer cells. Proliferation of progenitor cells in the bone marrow will result in replacement of the normal hematopoietic cells, and bone marrow failure will occur. That is why in most cases you will see the pancytopenia. So this is the bone marrow vasculature. You see a lot of granulocytes, megakaryocyte, and erythroid islands where the red cells are. That is the normal bone marrow vasculature, and this is the leukemic bone marrow vasculature, filled with one particular type of leukemic cell. So you don't see the different cell types anymore. And these leukemic cells are also not good cells, so they will turn out not to represent any of the functional cells. That is why in the end, no cell is shipped from the bone marrow, so you have the pancytopenia. Okay, now we narrow down to the acute leukemias in detail. Okay. Let me mention here that if anybody finds that I'm at a speed faster than it helps them, please let me know, and then I'll slow down for you. Okay. So for acute leukemias, risk factors can be acquired or inherited. And acquired is when one is given cytotoxic chemotherapy, or if it is a myelodysplasia condition. And the inherited may be you have certain genetic predisposition that doesn't help you in repairing DNA defect in cell development, or there is immune defect. Others include Down syndrome. If you're a Down syndrome person, you are likely to produce an acute leukemia. Investigation include taking the history, so that will help with the genetic part. If people in the family have had it before and all that, and then doing physical examination, and that will be followed by blood work. And the blood work includes full blood count. So you look for anemia, that is low red cell, thrombocytopenia, low platelets, and neutropenia or hyperleukocytosis. You can find the hyperleukocytosis because all the leukemic cells will be most likely on the leukocyte lineage, or will be seen as leukocyte, and therefore they will count as white cells, and that is why sometimes you have high white cell count. But the functional cells will be minimal. Okay. In the smear, you see the blood cells. So for example, these blood cells may all be counted as leukocytes. So you may end up with the leukocytosis. But when you are looking for neutrophil, eosinophil, basophil, those ones, they will be in low amount. So you see the neutropenia there. Then you have dysplastic neutrophils in secondary AML. UNEs, you do urea and electrolytes, you do look for LDH, clotting screen for platelet count, LFT, PUN, creatinine ratio, septic screen if you suspect infection. Why? Because the white cell, proper functional white cell numbers have reduced. So these are some of the tests, blood work tests that can be done. And then you can also do imaging. So you can do chest X-ray or CT scan and look for pneumonia or mediastinal mass or lytic bone lesions. Then bone marrow biopsy, what do you look for? You can do cytogenetics on the bone marrow cells, immunohistochemistry, and then flow cytometry analysis to identify the lineage of the cells that have become leukemic. And you can check for blood cells in the bone marrow, which are usually greater than 30% of the cells in the bone marrow. Now, acute lymphoblastic leukemia is also known as lymphocytic leukemia. And so for epidemiology, the incidence is 1 in 50,000 people and has slight male predominance and is the commonest type of childhood leukemia. The peak age is 2 to 5 years, but may later increase to greater than 50 years. Findings specific to ALL, we mentioned examination, and in examination, you may be looking at enlarged lymph nodes or spleen. So they may be lymphadenopathy or splenomegaly. And splenomegaly is seen in 10 to 20% of the cases. And then central nervous system signs are more likely. With the blood work, anemia, which is usually severe, and there may be signs present. And the WBC count is variable, usually neutropenia, we mentioned that. In the smear, you see smallish basophilic blast with few granules and hand mirror cells. You see hand mirror cells soon. And clotting test, 10% of ALL present with DIC, disseminated intravascular coagulopathy or coagulation. And then in imaging, there may be a mass in the mediastinal area in some T cell ALLs. These are the hand mirror cells. They look like hand mirror. Okay, and then you have small basophilic blasts with few granules in them in here. Okay. Then acute myeloid, also known as myelogenous, epidemiology 3.7 in 100,000, an improvement on the acute lymphocytic. Slight male predominance, commonest type of adult leukemia. So 90% of adult leukemia is usually myelocytic. Can occur at any age, but median is 70 years, which is a good sign. Findings specific for AML examination, lymphadenopathy is unusual, but you can find leukemia cutis, leukemic cells under the skin in 10% of cases, and choroma, which is rare. And then with the blood, you see anemia, severe with signs present. The BBC variable with neutropenia. With the smear, with the other one, we see the hand mirror cells, isn't it? With this one, you see Uya rods in large hypergranular myeloblasts. You see a picture soon. And there's hypokalemia in monocytic leukemia under the AML. And then clot in acute promyelocytic leukemia. So these are the Uya rods right there across the cell. Very classic. You can't mix that. You see it clearly. They are oddly shaped rods. Okay. What is the prognosis of the acute leukemia in general? There's a 5-year survival rate. So the 5-year survival rate talks about which people, the number of people who survive for at least 5 years after diagnosis. Even though we talked about the fact that diagnosis to death is 6 to 12 weeks if untreated, but if treated, you can never tell how long somebody can live with it. But usually in these conditions, there's a rate that is set at 5 years. So with treatment, you see that the 5-year survival rates in leukemias may improve. So therefore, in ALL, children, about 75% survive 5 years or more, adult 40%. AML 30 to 50%, but it gets better if there is bone marrow transplant, which is not easy to do. Great. Then we move to the chronic leukemias. Bear in mind also that I'm not really exhausting the leukemias. It's a very broad topic. So I'm summarizing the areas for us to get the whole concept of it. The risk factors for the chronic include radiation or immunodeficiency, example HIV/AIDS, or post-transplant or pesticides. Then it can also be inherited, so family history of chronic leukemia, CLL. 98% develop from B cells, and epidemiology incidence is 4.2 to 100,000. It has slight male predominance. Most common form of leukemia in the West, and usually greater than 55 years. Median age is 72. And it's rarely that you have people less than 40 having it. Pathophysiology, largely unknown with no specific genetic abnormalities. And the findings during diagnosis is that it's usually asymptomatic. And in examination, you find lymphadenopathy or splenomegaly present in late disease. And the blood work, the BBC is extremely high. Smear is lymphocytosis, smudge or basketball cells. And other conditions that can be found include Richter syndrome, where CLL will change into a lymphoma, and then pro-lymphocytic transformation as well. So this is the smudge cells, which is destruction of fragile lymphocyte during smear making. So when we are making the smear, the lymphocytes in this case are fragile, so they become smudged. And that is what you can see as the smudge cells. That's fragile lymphocytes getting smudged during film making. Okay. There is a step-up production of granulocytes and their precursors, and failed apoptosis, which leads to the insider's progression towards a blast crisis. So what is happening is that during the cell development, they fail to differentiate into the next level of lineage, and therefore they remain as young cells or blast cells, and they continue to cause the block the production of the normal cells. But because this development is inside us, you tend not to see it quick enough. The incidence for chronic myeloid leukemia is 0.6 to 2 in 100,000. They can occur at any age, but rare in children. Peak incidence are 40 to 60 and less common than AML and CLL. This is the pathophysiology. You may recall the Philadelphia chromosome, where there is translocation of the ABL gene from chromosome 9, which juxtaposes onto the BCR gene on chromosome 22. So chromosome 22 now get a fusion of BCR and ABL gene, forming the Philadelphia chromosome and leading to the active production of active tyrosine kinase, which then arrests the growth of the cells and results in the cells becoming leukemic. There's a 95% involved this translocation. The gene location is actually on the Q arm on region 3 band 4 for the ABL gene, and then it jumps onto the same Q arm region 1 band 1 where the BCR gene is. And then the other part of the chromosome 22 is jump to join chromosome 9. So it's actually exchange translocation or reciprocal translocation where genes are exchanged, but the problem occurs on the 22. Now the BCR cannot produce its protein, neither can the ABL, so they are fused, and it leads to constitutively active tyrosine kinase activity. That is what the fusion causes. Okay. So the findings usually asymptomatic. Examination, you have splenomegaly. Splenomegaly may be only feature at latent phase, but may be massive later on. And the blood works include anemia, which may be mild, and it worsens with progression. The BBC is extremely high, and when you do the smear, you may see leukocytosis or granulocyte showing a left shift. Granulocyte left shift meaning that there are young cells in there, a lot of band neutrophils are present. So the film is said to show a left shift. Okay, so here you have leukocytosis will increase the number of banded neutrophils. So when you see a lot of banded neutrophils, then you are looking at, it's going to give you a left shift. So more of the neutrophils will be young ones. Okay. Prognosis of chronic leukemia generally. CLL, you have BINET or RISE staging. We will look at some shortly. And then the median is approximately 10 years of terminal progression phase for 1 to 2 years. CML overall 5-year survival with imatinib now is 89%. So with treatment now, people who survive for 5 years or more are around 89%. Bone marrow transplant is the only curative therapy for this type of leukemia. So here we have a table showing comparing the two, acute and chronic, both lymphocytic and myelocytic, and okay, whether there is raised BBC or not. Anemia, does anemia occur? Do you have thrombocytopenia, lymphadenopathy, splenomegaly, or other ones? So this table compare them nicely for you right here. Great, so that sums up the summary for the leukemia. Then now looking at the myeloproliferative neoplasms, then you look at the lymphomas, and then if there is time, I'll go through quickly with autologous transfusion to add to this one. Okay. All right. So myeloproliferative neoplasms are said to be non-leukemic malignancies. And the three prominent ones are the polycythemia vera, where there is excess red blood cells, essential thrombocythemia, excess platelets, and mastocytosis, increased mast cells. We say that it forms part of a spectrum with CML, but all are closely related to each other. So if you have to be careful to see the difference in that. And associated with this condition, the myeloproliferative neoplasms are associated with the Janus kinase mutation. And JAK2 protein increases production of blood cells. So when there is a mutation and it's produced constitutively, it's gonna cause increased production of red or platelets, red blood cells or platelets. So the target cells are here: erythrocytes, mast cells, and megakaryocytes. They are produced in increased numbers. Look at polycythemia vera. And the polycythemia vera, the clinical features include night sweats, hyperviscosity symptoms, enlargement of the spleen, splenomegaly, hemorrhage, hypertension, and gout. So you have excess red blood cells, and they seem like there's a traffic jam in the blood vessel because the cells are too many. Important lab features include increased hemoglobin, hematocrit, and red cell mass, but there's low serum erythropoietin. Because the red cell content of the blood is high, erythropoietin production is minimized. And about 95% of these cases, you see JAK2 mutation. The treatment is venesection. Take some of the blood and discard. So you put them through phlebotomy, collect some of the blood and discard. Cytotoxic myelosuppression may be seen or used. So you give the person cytotoxic medication to suppress the production of the myeloid cell. And example of these include hydroxyurea and busulfan. Okay, everything is shorting. So we go to the lymphoma.
Hello, sir.
Yes.
Yeah, why is that we don't give out polycythemia blood during
Why is
blood
it that?
transfusion?
Say it again.
We don't. Why is that we don't give out a polycythemia blood during blood transfusion?
Why we don't give that blood?
Yes.
Yeah, because the red cells are many, not simply because the person has just produced them. So there could be some abnormality to it. So it's not indicated to be used for transfusion. They're actually taken for treatment purposes. That is, reduce the person's number of cells. So usually the protocol says that they are not to be used for transfusion because there are defects with it. And you can never tell what can go wrong with those cells as well. So for treatment protocols, that also covers blood therapy. You are not supposed to give polycythemia vera blood to people for transfusion unless it is not known. And if the person comes to donate, then you can't tell. But if they are diagnosed with polycythemia, which is a malignancy, if you recall the general topic, then that blood has a problem. And so you don't give it out to people. Is that okay?
Yes, sir.
Okay.
All right. Thank you.
You're welcome. So with Hodgkin's lymphoma originates from B cells in the germinal centers of the lymphoid tissue. So in the lymph node, there are B cells in the germinal center in the lymph node. And these B cells tend to have the malignancy and they proliferate uncontrollably within the lymph node. And that results in the lymphoma. So it's characterized by the orderly spread from one lymph node group to another. So it's going to see that the person will have the defects transmitting from one lymph node to another. And Hodgkin's lymphoma is characterized by Reed-Steinberg cells. We will see them soon, a picture of it. And the epidemiology is that they have 2.2 per 100,000 incidents. And 30% of all lymphomas are Hodgkin's lymphoma. There is, however, bimodal distribution with peaks between 15 to 30 years and greater than 50 years. It has slight male predominance. Risk factors include acquired through HIV or AIDS, or previous non-Hodgkin's lymphoma or autoimmune conditions. And it can also be inherited through immune defects or family history of Hodgkin's or non-Hodgkin's lymphoma can result in it if you have family history. So this is the Reed-Steinberg cell over here. It says some proliferation of malignant Reed-Steinberg cells, which is probably of B-cell lineage, and abnormal mononucleocytes. So this is a typical Reed-Steinberg cell. And that is what differentiates between Hodgkin's and non-Hodgkin's lymphoma. Classical difference. So you say that Hodgkin's lymphoma is characterized by Reed-Steinberg cells, whereas non-Hodgkin's lymphoma, you don't see Reed-Steinberg cells, okay? Presentation is there's painless, non-tender, rubbery, enlarged lymph node. And cervical involvement in 60 to 70%. And then there's axillary in 10 to 15%, and inguinal 6 to 12%. You have them under the armpit and then the neck region, the lymph nodes enlarged there. So it may increase or decrease in size spontaneously, may become mated and non-mobile, and there's continuous progression to nearby groups. Then you can have systemic symptoms, especially fever, which may be cyclic, and severe pruritus, itching in 25%. In other cases, you have early satiety due to splenomegaly. The spleen may enlarge and fill the tummy, so you eat a little and you are full, or you feel like you are full. The investigations include full blood count, and when you do this, try to exclude leukemia and mononucleosis. You can also do the acute phase proteins such as ESR and CRP, check liver function tests, urea and electrolytes, and checks X-ray looking for lymphadenopathy and mediastinal expansion. You can also do computer tomography of the thorax and abdomen for staging, and then bone marrow biopsy. Other tests include HIF spot, monospot, LDH, thorax intensives, get some fluid from the thorax and examine, or do PET scan, positron electron tomography, and MRI scan, magnetic resonance imaging. So this is the ultrasound scan excision biopsy of lymph node. And the lymph node has been taken and going for pathological examination, and you look at the lesion and look at the cells within the lymph nodes. Okay. So this is the CT scan down here with malignant nodes over there. That's the aorta, trachea down here, and then the nose there. You see, it's over here, enlarged. This one is very classically enlarged right there. Then you have the trachea, and then the mediastinal node is somewhere there. And then that's the chest X-ray looking for the mediastinal node. That is the neck region, lymphadenopathy. The Ann Abbott staging is used to diagnose the level of the disease. And the first one is that if you find a lymph node, an enlarged lymph node, one enlarged lymph node above the diaphragm, then it's stage 1. If you find 2 or more above the diaphragm, it's stage 2. And if you find 2 or more above the diaphragm, 1 below the diaphragm is stage 3, 2 or more above, 2 or more below is stage 5. And the higher the stage, the poorer the prognosis. Okay. Then you look at non-Hodgkin's, a heterogeneous group of lymphoid tumors, mostly of B-cell origin as well. It's characterized by irregular pattern of spread and common extranodal disease. They vary in their aggressiveness. Incidence 17 in 100,000. Median age is greater than 50. Diffuse large B-cell and follicular is common. Risk: acquired infection, example, Epstein-Barr virus. So that is what leads to the Burkitt's lymphoma. So Burkitt's lymphoma is a typical non-Hodgkin's lymphoma. Human T lymphocyte virus 1 of T cell, and then H. pylori in the gastric mold, mucosa-associated lymphoid tissue in the gastric region. Previous chemotherapy or Hodgkin's lymphoma can lead to non-Hodgkin's lymphoma. And I mentioned that the difference is the development of Riesenberg cells. Autoimmune disorders can also lead to it, or immunodeficiency, example, post-transplant, and then inherited conditions as well. How does it present? Painless, non-tender, rubbery, enlarged lymph node, and that leads to non-continuous progression. Then systemic symptoms, common in high grade. There can be rash, ketone, that is involvement of the skin, rash on the skin, abdominal pain or early satiety, splenomegaly, but unusual as rarely massive. Then you have hepatomegaly, then you have testicular mass in the testicles, and then GI, and you have symptoms of obstruction. There could be shortness of breath, psoriatic chest pain, mediastinal mass in high grade, and neurological conditions such as primary central nervous system lymphoma. And this one is common in immunosuppressed people. So quite a lot of presentations in this condition. Investigation. The laboratory investigation includes full blood count, ESR, LFT, serology imaging, and bone marrow biopsy. All these are indicated for testing to identify non-Hodgkin's lymphoma. So this is an ultrasound scan, lymph node ultrasound scan, and excision biopsy of the lymph node if you do the histology staining of the tissue. And that ends the hematological malignancy. So as you could recall, we touched on all the areas, including the defective white cell, defective red cell, defective platelets, and then defect with specific types of the lymphocytes, talking about the lymphomas. So I'll pause here. If you have a question, we can do in the next 8 minutes, and then because we have good time, I will do the autologous blood transfusion as well. Okay. So if you have a question, please go ahead, and then we will study autologous blood transfusion and end the day with it. All right. So let me stop sharing and look for the autologous. Autologous blood transfusion. Okay. All right. Okay. So give ourselves about 5 minutes water break. About 5 minutes water break, and then I'll start autologous. All right. Okay, so I am back, and we can look at autologous blood transfusion. It covers introduction, categories of autologous blood transfusion, advantages and disadvantages, indications and contraindications, and then the difference: preoperative blood collection, acute normovolemic hemodilution, and intra and post-operative blood collection, the different ways of doing it. So with introduction, autologous blood transfusion, that will be abbreviated ABT, is that you reinfuse blood or blood product taken from the same person into that same person. So just like auto transplant, where skin is taken from your body and used to decorate a different part of the body. One blood is taken from this person and put back into the same person. You are practicing autologous blood transfusion. So it says in point number 2, the autologous blood donation is a process of donating one's own blood prior to an elective surgery or medical procedure to avoid or reduce the need for an allogenic, that is somebody's blood, transfusion or transfusion of blood from a volunteer blood donor. A transfusion of blood taken from a donor to a recipient is what is called allogenic or homologous blood transfusion. So to avoid allogenic or homologous blood transfusion, you can do autologous blood transfusion. It is not a new concept per se. It started when pure blood transfusion with regards to transmission of diseases led to thinking outside the box. So people who are afraid of taking somebody's blood led to the exploitation of this way of blood transfusion. So it says reinfusion of blood was employed as early as 1818. In the 1930s, right? Some blood salvaging was reported during neurosurgery, surgical obstetric procedure from 1936. So this thing has been long practice. And in the last 20 years, there's been an increase in the use of ABT. And technological advances made it possible the development of safe and easy to use devices. So they are devices that can recover blood for reinfusion, even at surgery. Okay. So the pre-autologous blood, the process involves pre-autologous blood transfusion interview. And this is conducted at the donor center prior to the first collection, and the risk involved are explained to the person. And this procedure includes the donor consent, informed consent. Informed consent is that they just don't put a piece of paper in front of you and ask you to sign, but the thing will be explained to you. So the decision you make, it will be an informed decision. And then you sign donor declaration forms. Screening bloods will be collected. So your blood will be collected for screening, and you'll be given iron and vitamin tablets normally to boost replacement or boost up the blood before some is even taken. So the patient is assured the advantage of autologous blood transfusion is that the patient is assured that the blood that they will get is exact match to his or hers, and so avoid many of the complications associated with allogenic transfusion. And these complications include acute hemolytic reactions, allergic and febrile reaction, transmission of diseases such as hepatitis, AIDS, syphilis, and malaria to a less extent. And then conservation of blood resources. We have to go around begging people to give blood. But if everybody who takes blood is the same person who donated it, then there wouldn't be any pressure on blood storage. So autologous blood donations supplement the community blood supply. It reduces the need for blood donation. More on the advantages: avoidance of immunosuppressive effects of allogenic transfusion. Patients with rare blood group also benefit because if you were to look for their group specific blood, you will struggle. So the person is say, O negative, very rare to get. Because they themselves have donated their blood, you don't struggle to go and look for it anymore. This procedure allows availability of fresh whole blood for transfusion. You are sure there's a fresh whole blood waiting for you. And the process of donating blood promotes blood cell production by bone marrow. So when you donate blood, it stimulates your system to replace them. And so you donate, you produce fresh cells. Then the patient is often reassured by the knowledge that his or her own blood will be used if a blood transfusion becomes necessary. What is the disadvantage? There can be contamination of the blood with infectious agent during the donation process. That is possible, or in the storage process. The blood can also be mislabeled, or that allogenic blood will be inadvertently transfused. The blood should be labeled with Mr. A's name, can be mislabeled with a different name. Or when they come for it, for transfusion, and the technician cannot find it, they will take any other blood and cross-match and send it. Autologous blood donation costs more to process and store because the person's own blood and all that. The processing and storage may cost a little bit more. Blood may be transfused unnecessarily. The person's condition doesn't really indicate that they need a transfusion. Several times, blood is prepared for people undergoing surgery and they end up not needing it. The same way can occur, but here, because the person has donated their own blood and it's just chilling in the fridge, they will go and take it that they should be transfused with it. So they can be transfused unnecessarily. Unused units of autologous blood are usually disposed of. Approximately 44% of autologous donation remain unused after surgery, and mostly they are disposed of. Why? Because they may not have undergone stringent screening. Because it is known that they are going to be given to the same person, they don't go for infection testing and all that normally. But as was somebody asked about the polycythemia case, can autologous blood be given to somebody if the owner didn't use it? Yes, it can if it is taken through the routine screening like any other allogenic blood. So in that case, it becomes allogenic blood and it must be treated as such. Then it can be given to someone. What is the indication for autologous? Major orthopedic surgeries is an indication. Cardiovascular surgeries, obstetric surgeries, hysterectomy, ovarian tumor, radical prostatectomy, and mastectomy. And then gastrosurgery, blood collected in thoracic or abdominal cavity due to organ rupture or surgical procedures can also be used. So these are the indicators. Let's see if they are contraindicators. Yes. If there's evidence of infection and risk of bacteremia, you don't do it. Unstable angina, active seizure disorder, myocardial infarct, or cardiovascular accident, significant cardiac or pulmonary disease, cyanotic heart disease, uncontrolled hypertension, and malignant disease. In all these conditions, autologous transfusion is not indicated. Side effects. Some people feel lightheaded or dizzy during or after the donation, and they can even faint. Sometimes the bruise may appear around the place where the needle was inserted, and the area may be sore to touch for some time. This happens to even allogenic blood donors as well. Patient may feel fatigue for some time, and they may be fainting episodes. Techniques. These techniques are the different ways that autologous blood transfusion can be effected. And these include 3 different techniques that are available. We have the preoperative blood donation, and we'll talk about each one of them briefly. We have acute pneumovolumic hemodilution and intra and post-operative blood salvage. What are the advantages, applications, and complications for these ones? They may vary for each technique though. So let's do the preoperative autologous donation. This one is like the normal blood donation. So it can be considered before any elective surgical procedure where it is expected that the person may lose some significant amount of blood. The blood donation, transfusion, and storage units of blood are drawn from a patient, usually starting in the short-term case, 3 to 5 weeks before an elective surgical procedure, and stored for transfusion at the time of the surgery. So blood is taken and stored 3 to 5 weeks before the surgery, and if need be, given back. So it's just like you donating for someone. But in this case, they keep it and give it back to you when you need it. What is the patient selection criteria? Any patient with an adequate hemoglobin level qualifies. And those who are not, that is those who are not anemic, yes. So a patient weighing 50 kg, hemoglobin greater than 11 grams, hematocrit greater than 33%, can donate 450 ml of blood safely. Those with lesser body weight can donate proportionately lesser volume. Adolescents and children below 10 years can be candidates if he or she is cooperative, and particularly children weighing over 65 pounds. Elderly patients can safely donate. Obstetric patients, no adverse effect for mother and baby are reported, so they can also do it. A history of hepatitis B or AIDS is not a contraindication because you're putting the blood back into the same person. Unstable angina, severe coronary artery disease, severe aortic stenosis are considered as contraindications. Those who are having planned surgery that routinely require transfusion, except in cases where long-term storage is desired, may also qualify. Those who have no medical condition that could cause problems during or after the blood donation process qualifies as well. And this is the collection procedure. So it begins 4 to 5 weeks or 3 to 5 weeks before the proposed surgery, depending on the number of units required. So you can do 1 donation per week. And in 5 weeks, you can have 5 units of blood. And to prevent anemia due to donations, iron tablets are usually prescribed, and there's no special complications to pre-donations. Vasophageal reactions for which treatment is needed can be done. So this is higher in women and first-time donors. Time interval between the last donation and the surgery should be more than 72 hours. Take note of that. Then storage of the blood. The blood must be separately labeled with the patient's name and ID number. And then the ABU and razor typing must also be done and labeled. And this will help identifying the patient further. Screening for hepatitis B and AIDS are not mandatory. And that is why you have to be careful if you are to give autologous blood to someone. You have to make sure that these tests are done, but they may not have been done. No cross-matching is required. But if you want to be on the safer side, just in case the blood was switched, you can still do it. If CPDA1 is used as preservative, the blood can be stored as whole blood for 35 days, the longest. I think the longest storage is 42 days. Separation into plasma RBC increases the shelf life to 42 days. And if more storing is required, the RBC can be frozen and stored and used afterwards. The mere availability of pre-donated blood is not an indication for transfusion, but most cases, we see that is what happens. So, but a more liberal policy is usually followed because of the lower risk. Unused blood, as a policy, I think I have said this before. Unused blood as a policy is discarded, but after proper screening and cross-matching can be used for other patients. Okay. What are the complications? Complications include volume overload. That is, if the transfusion wasn't really indicated and you still gave the blood, then circulatory overload may occur. If the blood was contaminated, you will promote sepsis, and clerical error may lead to transfusion of wrong blood. Then we have the acute normovolumic hemodilution. What is this one? In this case, there is a removal of the blood from the patient immediately before or just after the anesthesia is inducted. And when you remove the blood, you replace it with a sanguineous fluid. There is no pre-donation, no pre-donation. So donation is done at the time of surgery. And the lost volume is replaced by these sanguineous fluids, such as crystalloid or colloids. These are aqueous solution of mineral salts or gelatin. So blood is collected at the start of surgery and the fluid volume loss is replaced with appropriate IV solutions, and then finally, stored blood is reinfused after the surgery. So you take blood from the right arm and apply the fluid to the left arm. So if you take 3 units of 400 each, 1,200 milliliters, then you add the same amount of fluid. That is what is called normovolution hemodilution. Normovolumic hemodilution. So you add the constituents to hemodilute the blood to the level that it used to be before the surgery. Advantage: provide fresh whole blood for transfusion. There's no biochemical tracing associated with storage Removed blood is kept in the operating room at room temperature, so no chance of hypothermia. Sometimes nurses keep blood for transfusion in the fridges at the ward, and when they take it, they don't allow it to thaw thoroughly or gain room temperature before they go and mount it. That can result in hypothermia in the patient. That could be fatal. Platelet function is preserved. The blood doesn't stay for long. Platelet die in 5 days, isn't it? So if you store blood for 20 days, you should expect the platelet to have died. No reduction in oxygen carrying capacity occurs. RBC loss during surgery is less as it is diluted with exsanguinous fluid. So the person's blood is diluted. So if you lose a liter, you will not lose the same amount of rest as if the blood wasn't diluted. Okay. Hemodilution decreases blood viscosity, which also improves tissue perfusion during surgery. More on the advantages possible during emergency surgeries, it can be used. Patients with systemic diseases also can undergo NIH as they are not ideal for pre-donation. No decrease can decrease the use of allogenic transfusion, to 50 to 90%. So if people were donating and reusing their blood, the allogenic transfusion will reduce. So as we need only 1 or 2 units of blood for most of the surgeries, which is possible by ANH. ANH is simple and less expensive than pre-donation and cell salvage, which we will come to soon. So the patient selection for ANH is any patient with an adequate hemoglobin who is expected to lose 25% of estimated blood volume qualified. Both children and elderly can donate. Overall health status of the patient is more important than the chronical age though. Patients with general, vascular, spine, orthopedic, obstetric, and plastic surgeries are good candidates. And look here, even the Jehovah's Witness patients also agree to ANH. We know people of that faith do not take blood. They say it's eating somebody's blood, so they don't take it. But in this scenario, because it's their own blood, some even accept. Contraindicators, if hemoglobin is less than 11 grams or hematocrit is less than 33%, then we expect anemia and such people don't qualify. The decreased renal function is a relative contraindication because of the excretion of diluent fluid may be, and severe carotid artery disease, severe pulmonary dysfunction are relative contraindicators. ANH technique, so say blood is withdrawn from a central peripheral vein or radial artery. Blood is collected in a standard bags containing CPD, and then crystalloids or colloids are infused as blood is withdrawn. So crystalloid is 3 times the volume of blood removed. If you are giving crystalloid, give 3 times the volume of blood removed. Colloids equal to the volume of blood removed. Dextran, albumin, beta starch, no significant difference, give the same. Crystalloids have the advantage of easily excreted by diuretic at the time of re-infusion. All these can keep pressure on the kidney. To label the blood of patient's name, hospital number, time of removal, and you number it sequentially 1, 2, 3, 4, 5. You keep the blood inside the same operating room at the room temperature. Blood is reinfused after major blood loss or sooner if indicated. The units are reinfused in the reverse order of collection so that the first unit, which has high hematocrit and most clotting factors, is administered last. So you don't go and clot the person's system. Okay. myocardial ischemia and cerebral hypoxia are major potential complications, but are very rare in usual circumstances. But next, okay, last one. Intra and post-operative blood salvaging within the surgery and after surgery blood salvaging. So here, there is a need for special equipment, and the blood is collected from the operative field and draining sites. Recovered blood is mixed with anticoagulant collected in a reservoir filter, and the filtered blood is then washed with saline. The red blood cells suspended in saline are then pumped into a reinfusion bag. Most of the WBC platelet, clotting factors, cell fragments, and other debris are eliminated. Several automated devices are also available for use. So here, blood is salvaged from the surgical area during operation for reinfusion. Let me see if there is, So the blood is collected after the surgical procedure is complete by draining of the operative area, and that blood is processed and reinfused. So as the person is cut, all the blood that will drain into the body that will be suctioned out will be collected into a tube, processed, and reused. The characteristics is that hematocrit or processed blood is about 50 to 60% and can be varied by altering the processing parameters. Oxygen transport properties and survival of red blood cells are equal or superior to stored allogenic blood. Processed blood has high 2,3-DPG level, and pH of salvage blood is alkaline, and potassium and sodium levels are normal. These were tested for research-wise. Okay, what is the aftercare for autologous blood donors? Individuals are generally given fluids, just like the regular blood donors will be treated, or light refreshment to prevent possible side effects such as dizziness and nausea. Iron supplements may be prescribed to prevent or treat anemia. Summary: autologous transfusion can significantly decrease allogenic transfusion. Yep, you said that. And appropriate to employ several blood conservation techniques. In appropriate cases, pre-donation is beneficial, and ANH is beneficial for providing fresh blood. Routine use of intra and post-op blood salvage is not justified, and newer processing devices may improve cost effectiveness of this process. And that will be the next thing. Is if you have any question, shoot at me. Right. Any question? All right, so silence across board means there are no questions. Bismarck. Bismarck, you are muted. Okay. Are you talking? I can't hear you. Is Bismarck speaking? Or you muted again? All right. You can put it in the chat. Let me see what you're saying. Okay. Bismarck, I wish you could elaborate further on your question, but let me see if how I understand it is correct. In the event where the blood will not be sufficient, what happens? I gather you probably are talking about the preoperative salvage case. So the blood taken from the patient will not be enough. At least it will hold them until allogenic blood is asked for. Even let's say you have pre-donation, and you see the interview will cover all that. So the interview will cover the fact that should the blood you donate not be enough, will you allow for allogenic transfusion? You will say yes. So let's say you donated 2 units, even in the normal case, the first one, before the elective surgery. And during the surgery, you tended to bleed far more than the 2 units, and maybe 4 will be needed. Because you have also agreed to be given allogenic blood, they will bring allogenic blood to supplement. Medical or medicine or therapy is to keep somebody alive. All we do in the hospital is to keep people alive. So unless the person said that no matter what happens, I don't want anybody's blood, then you give them what they donated and then leave it at that. But obviously, even if they needed 5 units and you give them like 2, they should be able, I mean, that shouldn't let them die. So as mentioned earlier, before the whole procedure is started, that question will be covered. And so it will be known whether this person will accept autologous, I mean allogenic or not. So that right after the when the surgery is done and you need more than you have donated, then they can add the allogenic one to it. So that is how it will go. I hope that answers your question. Okay, that's fine. Is there any other explanation needed?
Yeah, Prof, good evening.
Good evening.
Yeah, please, I would like to know with a case with autologous blood transfusion, maybe in a case where maybe you in one of the submission, you said that hepatitis B and HIV are not mandatory.
Yes.
Yeah, so maybe let's say at our setting, we normally for autologous transfusion, we normally do hepatitis B have to do with the donors.
Yes.
So let's be in the case where maybe you've checked for HIV and it's positive or reactive. So will it still go ahead to? So give that blood to that autologous client, or you discard it? Or how are you going to go about that case? If that's the first
So
time
the person is aware they have the condition.
No, the person is not aware.
Well, you let them be aware then. So one way is that, as I said, it's not mandatory, but it doesn't mean it cannot be done. So one, let's say you, Timothy, shows up, and then you have surgery next month. So you decide that you want to do autologous, and you take 2 units of your blood, waiting for the day you have the surgery to be given to you. And that blood is not screened for those viral infections. And we are very sure that is the same blood. So you needed the 2, and we gave them back to you. If at some point you go to test positive and decide that the hospital gave it to you because they may have switched your blood or something, then you sue, and the hospital will bring all the evidence to show that they didn't switch your blood and that the condition may have been pre-existing. However, if they also take the blood and decide to screen and find out that there's a viral infection, that is before the transfusion, they have to tell you. Then you do the test to also confirm that the viral infection is with you before the procedure will go ahead, and then they will give you back the viral infected blood. That is how it works. But if they didn't screen, then they wouldn't know. But again, to be on the safer side, I would recommend screening. But it is not mandatory as in allogenic blood. In allogenic transfusion, screening is mandatory. But in autologous, it is not mandatory. That being said, nothing prevents a facility from doing the screening. Because of the unforeseen circumstance where the person may tend to sue that they didn't have an infection and you're giving it to them, you go through a lot of trouble trying to explain or proving your case that you didn't change anything. And you probably will have a negative publicity for the facility. But if you were to screen, and then you know what you have gotten from them and what you'll be giving back to them. So if you screen and you find something, you let them know. And if they say it's not true, they go and do the test. So you find hepatitis B and they say, I've never had hepatitis B. Okay, go and do normal hepatitis B. Let's see. If you go and do it and it's negative, then the screen of the blood is also has a problem. If you go and it's positive, then you convince yourself, then we tell you. So you give your blood back to you, but it will contain the virus. You said yes, and then you get it back. So this is how those situations should be handled. I hope I've enlightened you, Timothy.
Prof.
Yeah. Did you get my explanations? Yeah, Timothy, you are muted. Did you catch my explanation?
Yes, Prof. Yes, Prof.
Okay.
Thank you.
All right. Okay, folks. It's getting to that time. The information I have is that the moderators are gathering this weekend to select the questions for the exam. So keep preparing. Go through some of the normal practical things that you do. Refresh your minds on them. Those of you working, refresh your minds on procedures and test outcomes and stuff like that. Those not working, think through things that you have done in the lab, supported by the theoretical things that we have been talking about. And hopefully you should be fine at the end of it all. So I think in a week or two, I'm not sure of I don't know if the exact exam date is come out. But usually after the examiners meeting is a week or two, then the exam will be written. So I know we're going for it this coming weekend. Okay, so that is a little information for you. All right.
Yeah, Prof, please, this time the question should not be one way, because the main exam, most of us, we had challenge with the question. So please,
Okay.
as the administrator has informed you last week, it is most of us are concerned because the way things went, we were not happy with it at all. Okay. But we can't blame them. We just have to blame ourselves because we needed a pin and the certificate. So we can't go to school for 4 years and the writing the last shall become difficult things for us to move ahead. So please, Prof, your children are really going through a lot. So you have to do something for us.
No problem at all. As far as I am concerned, it shouldn't be a problem. I'll talk to the medical lab team. I think I will be there. I'll be going as well. So the other person or persons that will show up, we will talk. Like I said last week, it's supposed to be representative. It cannot be one side. Even the hematology area shouldn't be one-sided. So every part of the medical lab is supposed to be covered. So maybe 25, 25, 25 or something like that. I know a lot of people don't like pathology. So I normally, if I'm involved, don't take too much pathology questions. In there, maybe 10 or 15, and then micro 30, the other one 25, 25. And then we go. So we will talk to them and make sure that it's not skewed towards one side, such that if you didn't practice for that one, then you lose out entirely. So let's use this as a benchmarker, and hopefully you should walk out of that room feeling good about yourself. So I will apologize on behalf of the council for what happened the last time. We ourselves have seen it. So that is why they are getting back to the people who used to do it. I mean, the change of the personnel was causing a problem. Ideally, a senior person doesn't go to set questions and a junior member go to select the final ones. You don't do that. And those things happened. So we have entered the complaints. We got them and we entered, not as examiners, but as people who run schools. We also complained and they have listened. So let's see how this one goes. I don't promise, but I can give an assurance that it shouldn't be a bad situation. Even the last time, I was sure I was going to be there, but as the time was being planned, I think I got other things came up, so I couldn't go. But this time I plan to go. So if I'm going to be there, then I will send your sentiments across and we will do the best we can for you. So be rest assured, all right?
Probably, of course, financial loss to us. So. Because
So
probably
you
it's
see
true.
us for
They really cause
financial loss to
financial
the
loss.
state.
Yeah, they've caused financial loss
They
to
can.
really
It's possible.
register and pay
Yeah.
for extra classes. Prof,
Yeah, I
these
know.
are hard truths that some of us we can't speak about it.
Yeah, yeah.
So please, Prof.
I know. You know, it could have cost somebody even their job. So not only the loss in paying for extra classes and stuff. People could have lost their job if they say bring your PIN and you don't have. You can even lose
Exactly.
your job. Yeah. So
Please
we appreciate all that. Yeah. Yeah. But of course, like I said, we can only complain, but now the council is listening better than before. So hopefully such situation will be avoided. I mean, the 5, 6 or so years ago, when I was part of the team, we used to have 100% pass. You were doing 90, 100% passes, you know, until things came and the number dropped. But we hope that it will come back to the high percentage passes as well. Okay. So no worry, Gideon and all the team members, we understand. We hope it will turn out well. All right. So you guys have a good evening and we will meet again.
Thank
I wish
you,
you
Prof.
all the best.
Thank you,
Thank you,
Prof.
bro.
Yeah.
We believe this we are making it once and for all.
You will. You will.
Amen. Amen.
Okay.
Thank you, sir.
Yeah. You're welcome.
Thank you, sir.
Hmm.